Do they call you Mr. President, by the way?
I'm encouraging that, but so far it seems to be mostly Skip.
Believe me, if I'm ever asked, they're going to call me Mr. President every time. I would love that.
This is Blood and Cancer, the official podcast of MDedge Hematology Oncology. And I'm MDedge editor, Mary Ellen Schneider. I'm filling in today for Nick Andrews. And you just heard Dr. Skip Burris, this year's president of the American Society of Clinical Oncology, and our podcast host, Dr. David Henry. We've got a really great show for you today. Dr. Henry recently sat down with Dr. Burris to find out what it's really like to be ASCO president. Dr. Burris shared his vision for what he's trying to accomplish, but he also talked about what it takes to juggle this type of leadership role with his day-to-day clinical and research responsibilities. Later in the show, we'll have clinical correlation with Dr. Ilana Yurkiewicz. In this episode, Dr. Yurkiewicz shares a story about a couple she met who had advanced cancer at the same time. Leave it to Dr. Yurkiewicz to make this a really uplifting story, so stick around. But first, here's Dr. Henry.
Welcome to this podcast. I'm Dr. David Henry, and you are listening to Blood and Cancer. We are the weekly mailing out to wherever you get your podcasts from mdedge.com/hematology-oncology, which is our online journal, and which also has show notes from the podcasts that we put out each week, hopefully of interest to our listeners in a hematology or oncology topic. And I'm really delighted today to be talking to one of our editors who has taken a side job this year with ASCO. He is our current president, Dr. Skip Burris, who is Chief Medical Officer at Sarah Cannon. Skip, welcome to this podcast.
Thank you very much, David. I appreciate the opportunity to speak with you.
Well, you're very welcome, and I've been looking forward to this because, you know, I know how things are with you and running as Chief Medical Officer and research and speaking and seeing patients busy enough, and then there's electronic medical records and training fellows and so forth, and then you're ASCO president. So I have a couple questions that I can't wait to hear, and our audience will as well, I'm sure, beginning with, what's it like? Is it everything you thought it would be being the ASCO president?
So it's been exciting. I think it's fair to say that while you have your ideas of what it might be like, things are always a little bit different. But I think the most important thing is it's also been fun. The ASCO staff is fabulous. So those full-time employees that are there supporting the organization, really quite knowledgeable, fabulous to work with, very considerate of time and considerate of my other obligations, and are really a great group to work with. And most importantly about that group, I think it's a very member-centric and a very patient-centric group. So that certainly facilitates the ease in doing the position.
So how does it work? So I know what you do, or maybe you could say for our listeners what you do ordinarily every day, every week, and then layer on top of that how you then interact with ASCO to run the whole system for a year.
Absolutely. Yeah. It's, you know, the good thing about the way it's set up is you are elected, and then there's a few months before you become the president-elect, and that really gives you some time to begin to delegate and organize. The few things that I did to help myself out once I had been elected was to cut my clinic back. I've been taking limited new patients, and I've moved from 2 full days of clinic to 1 full day with some new patients or need to seize on other days. I also delegated some of my responsibilities to some of our other physician leaders at Sarah Cannon, which has been great for them. I think with the need to get around to planning and succession planning and how organizations roll and plan for that. An event like being elected ASCO president does help accelerate the organization in that direction. So I think many of my colleagues have enjoyed the opportunity to take on some of those roles. ASCO is also very organized. So in terms of how the week rolls, there's often several calls that are involving governance decisions and committee meetings that are being held. Things are planned out well in advance. Today I was on the phone discussing a meeting that was going to be held next February, And then when I'm up at ASCO headquarters the week after Thanksgiving, we're actually talking about some meetings that will take place in April and May. So there's no procrastinating with the ASCO staff and leadership, and we do things well in advance. And then, not surprising to anybody listening, there's much going on in Capitol Hill today and every day. There's always the opportunity for ASCO to weigh in on legislative issues. I had anticipated this would be such, but rewarded to see that ASCO, our society, is really seen as the voice of oncology. And there's great respect from the legislative staff to get their truth from ASCO and to really have ASCO weigh in on various policy issues. And ASCO's got a great group that actually helps the president think through our answers to the questions and the problems that are ongoing.
Now, do you go to White House policymakers, Capitol Hill, meet with congressmen or senators, or all of the above?
So, with regard to Capitol Hill, most of the time is interacting with key legislators who are involved in particular issues. So, usually congressional staff. That's always interesting because congressional staff are a good bit younger than you would anticipate. But those are often the folks that are organizing the information and really teeing up their congressperson or their senator as to what the issue is. And so they're really, really interested in seeking the facts and some valued opinions on the matter. When you think of the executive branch, much of the interaction at that level really is with regard to Health and Human Services, Secretary Azar's office. And they also have some excellent staff that are very collaborative with ASCO and ASCO leadership and, truly interested in seeing what those opinions are. So I found it to be very much a two-way street, which is nice. There's a great deal of acrimony on a number of issues on Capitol Hill, but I would say in the area of cancer, that's something that does bring folks together.
I'm smiling because I was on the ASH practice committee a few years back, and we had an every 6-month visit to the Hill, and I remember distinctly being outside senator or congressman's office, and out came a young woman, 30 years old, and say, let's talk about your policy. I said, you? And of course, these staffers work very hard. They're very young, and they're very sharp. They usually know the issues, and they get to their person and hopefully make a difference. So I've seen exactly what you've seen. It takes a little getting used to because they are very young, but they're very sharp.
Absolutely. It is. You're right. It's a young group, but you realize the competition they went through to get those positions. Mm-hmm. And as you talk to them, again, they're respectful. A little bit of a blank slate, which is nice too, when you're telling them about the challenges that your patients are facing with regard to potential access issues or reimbursement issues. So in that sense, it can be a great audience to talk to.
So how big are we? Are we 35,000, 40,000? How big is ASCO now?
So great question. Being all things ASCO and being involved, I would have gotten that wrong as I joined. We are now about 45,000 members.
Wow.
We have about a third of those are ex-North America. So we've got about 15,000 members that are coming from Europe, Asia, and smaller parts from other parts of the world. When we look at the annual meeting, we're running a little over 40,000 attendees. And at the annual meeting, it is about half U.S. Based and about half ex-U.S. So we're seeing 20,000 international that are attending the annual meeting, and that's about a third of our membership. So quite a large organization. And they're one of the areas and one of the key points of focus has been trying to become a global society to help support those members. And there's certainly challenges with trying to be global.
So with being such a great organization, and of course the top, Mr. President, do they call you Mr. President, by the way?
I'm encouraging that, but so far it seems to be mostly Skip.
Believe me, if I'm ever asked, they're going to call me Mr. President every time. I would love that. But being at the top of the organization with so many different voices and so much diverseness to cancer care, do you get a lot of complaint? The staff probably insulates you. Do you get much complaint, much praise? How does that go? Or do they kind of filter? I guess they'd have to.
They do filter, but they also let you experience it. ASCO's CEO currently, Calif, who was not that long ago the ASCO president and the breast cancer researcher for Memorial, Calif gave me a heads up coming in that, our society is big and therefore diverse, and there's almost always an equal and opposite reaction to every issue. So there's folks that think ASCO is too big and folks that think we should be bigger, folks that think that we should always meet in Chicago and they love it, and folks that want the meeting moved around. And there's folks that weigh in on it being too academic and too community and too hospital focused. And so, you got to be careful there, because sometimes it is the louder voices that can attract the attention. Yeah. I would say the part that pulls it together, and this will certainly resonate with you, that when you get down to it, all of our colleagues that are members, and they're sincere in the fact that what they're really looking for is to make sure that there's access for our patients, that there's access to clinical oncology, that there's access to new therapies, and that there's access to clinical trials, and that they're looking to make sure that patients aren't disadvantaged by their socioeconomic status or where they live. So those end up being the common themes. While people are advocating for their rural location or their urban hospital, those central themes run through and through every conversation. So if you can keep the members realizing that it is all about access and opportunity and making sure that we're doing the best we can patient by patient, that's where we really have the common goals and the common interests.
Yeah, well said. Keep their eye on the ball. We're all on the same mission, and hopefully it all ends up being best for the patient. Well, that said, I would think as you come in, they want you because of who you are and what you've done and your wonderful reputation, and you would have an idea, 2 or 3, about things you might want to tell them, which is why they go after you. Do they ask you, or do you have a couple, 3 thoughts to accomplish this year or vision ideas?
That is part of the, as you go through and you're thinking about interviewing, and they are great, the ASCO leadership and staff, about what you would hope to accomplish. And so, ASCO's got some overarching strategic visions around making sure that the member experience is strong, making sure that they're doing things to keep quality of care at a high level, being fiscally responsible, and having the global impact. And so for me, and the background I had, much like yourself, emphasizing clinical research and taking care of a diverse population of patients, my theme has been very much around bridging the stakeholders. So when I worked into actually having a short theme, the idea of uniting and conquering to accelerate progress together was where we landed. And the key parts of that are, I wanted to make sure that Conquer was in the title. Conquer Cancer as the ASCO Foundation, and the investments that are made, really a unique foundation in that virtually all of the fundraising dollars go to support young investigators and young career development awards to actually enhance research. And so a little different than thinking about investing so much in a program or project like an R01, but you're actually investing in the best and the brightest. So I wanted Conquer Cancer to be front of mind. And then as we look at the membership and we look at where oncology is heading, we are actually in a full-scale initiative right now to try to better understand who our members are, what they need, and how we can best serve them. And we all know that the advanced practice providers, nurse practitioners and physician's assistants, that pharmacologists and pharmacists, that various elements of the nursing business, that having pharma biotech and the payers at the table are key, actually including the patient advocacy groups are necessary as well. And then the regulators, those folks that are actually approving and overseeing our new therapies, including them on committees, having them engaged in the annual meeting and having them engaged in the planning has been a key part of my vision. And I've highlighted that by having 2 fabulous educational and scientific program chairs. For the first time, we have an FDA regulator, Dr. Tatiana Prowl, who's also a breast cancer doctor at Johns Hopkins, as the educational program chair. And she has really rounded out quite a diverse educational program and committee. And then Melissa Johnson, who is a Penn med school graduate, a Memorial Sloan Kettering trained oncologist who's here with us at Sarah Cannon. Her background and her diversity in training, she has put together a similarly diverse scientific program, and we're hoping to get a great selection of abstracts and opportunities for showcasing some science at the annual meeting. So that's the theme, is bridging these unique stakeholders to come up with ideas and solve some problems that we can't solve in our silos or in our vacuums.
Well, I think those are such good points, and to highlight what resonates with me is, first half of my career was me, and second half they said, well, you need this nurse practitioner. I said, oh no, I'm just fine. Well, then you have a nurse practitioner. It's unbelievable. So the advanced practice providers, whether they be PAs or NPs, are like fellows, and they're wonderful, and they're starved for this kind of education. So the fact that even though they may have their own organizations, we include them at the table to help us know what's best for the interaction is great. And then something you said I really like is, we have the payers, we have the pharmaceutical companies, and we have us, and we all complain about each other and attribute some negative connotations to each other when really, we can't live without each other. And so I think bringing them to the table so we get our differences out in the open and then go forward, keeping the eye on the ball, as you said, is a really great idea. So I really like what you're doing and trying to take the organization this year.
Well, thank you. You're right. It is key. And, for having some of our colleagues sitting in different positions and the cross-fertilization between pharma biotech and some of our academic centers, we actually are seeing a scenario play out today where with the survivorship and patients doing so well with therapies, as you stated, we need these physician extenders, the nurse practitioners, and the like that are just so vital. And then the patient advocates. This is a interesting group of folks, and we are actually going to have a couple different type of advocacy groups, including in the meeting. We actually have several colleagues who have been cancer survivors and been through treatment, and we're going to highlight some of their stories, folks who've had to walk both sides of the street there in terms of being a physician and a patient. So there's much to learn. The future's never been brighter. And then at the same time, best and most appropriate therapy, the number of trials that need to be completed, and, how we begin to provide access to all so that there's a level playing field. Those are some real challenges. Well,
I think we'll draw our interview to a close. Really enjoyed speaking with you and hearing what it's like to be Mr. President. And have known you for a long time, and just really thank you for all you have done for us up to this point and continue to do this year with assuming the reins for the ASCO group and our meeting coming up. And so to remind our audience, we've been talking with Dr. Skip Burris, who is Chief Medical Officer at Sarah Cannon, a wonderful investigator, physician, and now our ASCO president for this year, and doing a great job. So Skip, thanks for what you're doing, and thanks for this podcast with us today.
Thank you, David. I really appreciate the opportunity to speak with you.
You're very welcome. And to remind our audience, this has been the podcast Blood and Cancer, and you can listen to many of these archived online, which come out every Thursday morning on our electronic webpage for this electronic journal, mdedge.com/hematology-oncology, where show notes are there also for the previous podcasts if you would just like to look at those as well as listen. And so that'll do it for today. Thanks so much. Thanks, Skip, again.
And that concludes the interview portion of the podcast. When we come back, we'll have Dr. Ilana Yurkiewicz and clinical correlation.
I'm Dr. Ilana Yurkiewicz, and this is Clinical Correlation, a segment about the human side of hematology and oncology care. Today, I'd like to talk about support. I've spoken before about how patients do better when they're lucky enough to have a support system of people who care about them, whether that be spouse, adult children, friends, whomever. These are the people who never come to clinic appointments alone and always have someone at their bedside when in the hospital. For the people who don't have that, treatment and dealing with cancer can be that much harder. But what happens when your support system is struggling too? What if your support, for example, gets cancer the same time you do? I recently met a lovely elderly couple whom this happened to. He was her bedrock, supporting her through an aggressive cancer requiring a lot of time tethered to an IV and in the hospital. Then their roles switched. Or did they? He was suddenly diagnosed with an aggressive cancer too. And now they were both tethered to IVs, just on different days, and trying to coordinate hospital stays. Neither could actually be fully physically present for the other's appointments and infusions. But in a less literal way, it actually made them more present. She explained to me how the concomitant diagnoses brought them closer than she'd ever expected because of a deep shared understanding. It was more than could be explained unless you were going through it too. And so while this of course was a devastating situation for everyone, it did allow them to support each other in unexpected ways. It's a lesson that having time and being physically present is not the only way to be supportive. A shared understanding, even with less face time, can be just as powerful. Thanks for listening, and I hope you'll tune in next time for Clinical Correlation.
And that concludes this episode of Blood and Cancer. If you want to hear more from Dr. Burris, he recently guest hosted some episodes of the podcast. You can see the whole library of Blood and Cancer episodes on our podcast website, mdedge.com/podcasts. And now for the credits. Blood and Cancer is hosted by Dr. David Henry. Clinical Correlation is written, recorded, and produced by Dr. Ilana Yurkiewicz. Nick Andrews is our audio editor, audio engineer, and the voice of MDedge Podcasts. All MDedge Podcasts are produced by executive editors Kathy Scarbeck and Denise Fulton, and multimedia editor Terry Rudd. And I'm Mary Ellen Schneider. Thanks for listening.